Good morning. My name is Joseph Timpa. I'm a perfusionist at Children's of Alabama, and I'd like to thank the Texas Heart Institute for allowing me to share our experience with exit. I have no disclosures except for these two Irish nuns once told my parents I was a Hail Mary away from an orange jumpsuit. There are a couple of ex utero emergency scenarios listed here, but today we will be concentrating separating from the cord and taking the baby to an observation room right outside the delivery OR and assessing if the baby needs ECMO for immediate support for a cath lab or surgical procedure. The exit procedure has been successfully used to intervene in several fetal disease states. These include, but are not limited to, congenital airway obstructions such as tracheal stenosis, atresia, neck masses, pulmonary and mediastinal masses, and congenital diaphragmatic hernia, as well as heart disease. In some instances, the exit procedure can be performed in order to transition to ECMO until further surgical interventions can be achieved, such as hypoplastic left heart syndrome and intact atrial septum. As you can imagine, the coordination and planning is very important. This is a paper out of Children's National in DC that discusses the implications, planning, logistics, and roles of an exit procedure. During the gestation of the child, there are field team meetings where OBGYN, cardiologists, surgeons, and the whole group meet. Just as I mentioned before, early detection of these complex lesions is imperative to achieving the best outcome. Once the lesion is suspected and confirmed, the multi-disciplinary team meets and discusses the approach for the possibility of exit to ECMO. Through regular meetings, this group of practitioners will develop a plan of action for the exit procedure. Establishing roles and responsibilities in advance prevents chaos and confusion during the procedure and eliminates overcrowding of duplicate practitioners. This is a picture of our facility. The brown building is UAB, connected by a crosswalk to Children's. The Women and Infant Center is the part of the University of Alabama that's connected. This was a vision of Dr. James Kirkland to create a continuum of care for neonatal through adult congenital cardiac services. The perfusionists at Children's also perform adult congenital cases at the University of Alabama, Birmingham. As I mentioned previously, the WIC, the Women and Infant Center, is next door and has a walkway that connects the two facilities. The two hospitals have worked together to establish credentials for all clinicians that may be participating in the care of the child in either hospital. As I mentioned before, since there's so many clinicians, there needs to be established roles set. Since different specialties often feel that they should be taking responsibility for the care of the neonate, communication on who will be the primary team for neonatal intubation, obtaining access, and the initiation of resuscitation if it becomes necessary. As I've mentioned before, simulation walkthrough is also important. Issues such as the space being used, the large number of personnel in that space, their physical location in the room, and equipment needed can all be determined ahead of time. Blood product availability and regulations from one hospital to another is super important. Transfusion and taking one blood unit to another hospital sometimes can be complicated. We've worked through some of these logistic problems, and we communicate really well with each other. Equipment such as point of care, the medications used, again, even transducers, as well as connections for air and oxygen, all need to be considered for a smooth transition. These are other examples of some of the small details that need to be attended to. Details such as getting samples of the mother's blood when she's in clinic, having a process to admit the mother in one hospital and the baby in another prenatally, having emergency release blood available for ECMO, monitoring air and O2 connections and transport monitors, and delayed cord clamping communication to increase the hematocrit of the baby so hemoglobin dilution is not as pronounced. I like this technique of delayed cord clamping. We can use the umbilical cord and delay the cord clamp to increase the hematocrit and help with the hemoglobin dilution of the ECMO circuit by using some of the mother's blood to prime the circuit. It also gives some immunity benefits, and you would think that it has some other benefits with stem cells that a lot of people haven't studied yet. Of course, our use of exit ECMO is for cardiac patients and neonates born with hypoplastic left heart syndrome or severe aortic stenosis, much of the blood flow to the body is pumped from the right ventricle through the patent ductus arteriosus. If there are no intracardiac mixing, pulmonary atresia with intact septum, early intervention is needed in those patients to increase the chance of survival to a palliative surgery. We have the advantage of being able to do this procedure because of the hospitals being connected. The small disposables and portable ECMO pumps have allowed the clinicians to increase the versatility of ECMO in small spaces. In addition, the emergence of a multidisciplinary ECMO team has helped standardize patient care and made the therapy more predictable and reliable. We've started to use exit ECMO strategies for early intervention in children born with complex lesions, especially intact septum. Yes. These are some of the criteria we used to decide if we're going to put a patient on ECMO, agreed upon ahead of time. The surgeon will place the ECMO cannula on the right carotid artery and jugular vein. Once ECMO has been established and the patient is stabilized, the patient's transported to the hybrid catheterization lab at Children's of Alabama to undergo a balloon atrial septostomy. The patient is expected to be weaned off ECMO within a few days. Again, these are some of the criteria and goals we've established. When the baby is born and brought to the observation room, SATs that are greater than 70, we transport to the Children's for conventional care in the ICU. SATs 50 to 70, we transport to the COA hybrid cath lab for septostomy or other procedures decided upon. And SATs less than 50, we initiate ECMO cannulation in the post-delivery area and transport to Children's hybrid cath lab for evaluation. Hopefully, we'll be able to wean these kids within a few days after the procedure's been performed, and then decide when the next palliation will be. We have a number of people on standby at both institutions. The perfusionist prep, we have a size-appropriate pump belt for possibility of conventional bypass if needed in the hybrid. The perfusionist is mobilized at UAB with a clear primed ECMO circuit waiting for the delivery, and then there's a COA ECMO team that also has a backup ECMO circuit built. The cath lab and CVO are open that day for the possibility of needing either surgery suites. Of course, this is a series of checklists that we have to make sure we have the appropriate equipment and a cart that we bring over. And of course, medications have to be received from the UAB pharmacy since we're providing care in that facility, as well as the ECMO carts being supplied with medications from Children's when we reach the Children's doors. And this was a product of simulation walkthroughs in the past when we were first planning for our first exit ECMO. So we've got a diagram here that shows where everyone will be placed in the room, in the observation room. It's a tight fit. It's a smaller area, but you can see circled where perfusion and the ECMO circuit will be placed in relation to the baby when it's brought out. And this is just a picture of the organized chaos that ensues when the baby's brought into the delivery room, from the delivery room to the observation room. This is just another picture of the tight fit and the cannulation. And these are pictures of procedures commonly performed in the cath lab on ECMO, balloon septostomy of the ductal stent to allow mixing. And this is a picture of our hybrid cath lab. We had 9 patients with hypoplastic left heart syndrome and intact atrial septum. 5 were placed on ECMO after delivery. Survival for total patients at ECMO was either mobilized or initiated at UAB with an emergent cath lab intervention at Children's Hospital were 85% survival for operative and 67% survival to discharge. Patients that received ECMO were cannulated an average of 34 minutes of life. And this study in circulation from OSF in Illinois showed promise in fetal intervention experience, but still showed only a 35% survival to discharge for intact atrial septum patients after intervention. Again, these early results of prenatally diagnosed patients with severe restriction are similar to those that CHOP presented by GLADS. This retrospective study of both prenatal and postnatal presentation showed that prenatal versus postnatal diagnosis did not improve initial hospital survival or cumulative survival for any degree of atrial restriction. In this single center study, all 7 patients diagnosed prenatally with severe restriction underwent immediate surgical or catheter-based intervention with an overall survival to hospital discharge of 28%. Although the study did not evaluate longer-term outcome, the established 2-year cumulative survival of all patients with severe restriction postnatally indicated only a 20% survival at 2 years of age. So our results we were pretty proud of. Obviously, this is a difficult subset of patients to take care of, and everyone doesn't have the luxury of having their maternal hospital connected to the children's hospital. We do not have a fetal intervention program. In the past, these patients would have died or soon after birth died. Exit-to-ECMO mobilization has shown to be potential to save patients that would otherwise expire. This population continues to be a complex group to take care of, even after early interventions. So again, in this study of our results, all 9 patients diagnosed prenatally with severe restriction underwent immediate surgical or catheter-based intervention with an overall operative survival of 85% and 67% to hospital discharge. Again, I'd like to thank Texas Heart Institute, Miss Deb and Miss Kathy for allowing me to speak, and hopefully I'll see some of you next week for graduation.